Hi, I'm Lee Crosby, dietitian and nutrition education program manager with the Physicians Committee. And before we get started, I'd like to briefly share our website I think you'll find useful. It's called nutritioncme.org. It's a free, non-commercial continuing education site where you can earn credits through the Physicians Committee and the George Washington University on a broad variety of nutrition-related topics. Now, let me introduce the man who needs no introduction, but Dr. Neal Barnard, president and founder of the Physicians Committee for Responsible Medicine and the Barnard Medical Center in Washington, D.C. He is also an adjunct professor of medicine at the George Washington University School of Medicine and Health Sciences. He's authored more than 90 scientific publications as well as 20 books. I'm also thrilled to be introducing Dr. Christie Cobb. Dr. Cobb is a partner at Little Rock Gynecology and Obstetrics, PLLC. She has a multi-generational practice that ranges from adolescence to postmenopausal women's healthcare. Dr. Barnard, Dr. Cobb, take it away.
Great, thank you so much. Dr. Cobb and I are going to be tackling really a new frontier in nutrition and medicine, and that's the effects of foods on our hormones. Because if you can affect your hormones by food choices, you are affecting far more things than we ever dreamed of. It's not just a question of foods affecting your weight, or your cholesterol, your blood sugar. It can affect a vast array of things that we had not ever thought could be connected with food. For me, I have to say, let me see if I can make this go. There we go. For me, this started with a phone call. A young woman called me up and said, I am miserable. Now, many women have menstrual pain, but for some, it's really off the scale. And I asked her to describe what she was going through, and it sounded really like torture. So I said to her, let me do this. I can give you some painkillers for a couple of days, which is what she asked for. But I started thinking about what is menstrual pain? And I realized that it's something that's under hormonal control. And at that point, as what I might call an educated guess, I suggested 2 steps for her in addition to painkillers right now. And I suggested over the next 4 weeks, how about no animal products? And keep oils to a bare minimum. And in a minute, I'm going to tell you the reasoning that brought me there. But I have to say, it helped her enormously. The next month, when her period arrived, she had no symptoms at all. That was true the month after that and the month after that. She said this was just a cure, unless she would break one of those 2 rules, including just greasy foods coming back into her diet. So that was encouraging, and based on that, the Georgetown University Department of Obstetrics and Gynecology did a randomized trial with me of this approach. We brought in a group of women. They all had moderate to severe menstrual pain, and half of them started the diet I just described, no animal products, minimizing oils. The other half got a supplement that was in fact a placebo. After 2 cycles, everyone switched. The diet group started the supplement group started the diet. And we tracked pain, PMS symptoms, as well as weight and lipids and other things. And in a word, it worked. The journal Obstetrics and Gynecology published our findings. And what we found was that pain intensity diminished, pain duration diminished, as did PMS symptoms. Let me just kind of walk you through this really quickly, if I may. First, as their period would approach, at baseline, there was 1.7 days of behavioral changes, which shrank to 1.1 days during the diet. Behavioral changes here means mood, how you feel. Then we looked at water retention, bloating. And at baseline, it was 2.9 days. But on the diet, it shrank to 1.3 days. So we could see something was happening with this diet change. And then when their periods arrived, we asked, how many days of any kind of pain did you have? And that diminished from 3.9 at baseline down to 2.7 on the diet. But then we asked not just what's the duration of pain, but what's the intensity of it? And what this on a numerical scale, the first day at baseline was a pain level of 7, the second day 5, third day 3. Then when they started the diet, when their period arrived, it was 6, 3, 0, meaning they had fewer days of pain and less intensity of pain on average. Now, the truth is, for some women, it was a complete elimination of pain. For others, it didn't do anything. The figures I'm showing here are just averages. So let me walk you through what's really happening. This is the amount of estrogen in a woman's blood during her reproductive years. And when I say estrogen, as you know, estradiol is the predominant one, but here I'm just calling them all estrogen. Okay, so at the beginning of the month, there's very little estrogen in a woman's blood. But it gradually increases, and at about 2 weeks, it reaches a peak, and then it falls. She's ovulating. An ovary is releasing an egg. Then over the next week, the amount of estrogen gradually rises, and that's because the uterus is the most optimistic organ in the body. Every month it is convinced, this could be the big one. We could be pregnant this month. So under the influence of that rising estrogen, the endometrial layer thickens up. But about a week later, the disappointed uterus discovers we are not pregnant once again, and the amount of estrogen falls, and the endometrium is discarded. But all of this can change based on foods. We'll come back to that. Okay, so this is the uterus, and off to the side you see the ovaries and the fallopian tubes. So that inner lining, the endometrial layer, will naturally thicken up every month under the influence of estrogen. So what if I have a little too much estrogen in my blood? Well, it thickens up too much, and as it does, these cells produce prostaglandins that cause pain. Okay, so, all right, estrogens will drive dysmenorrhea. How do foods get estrogens back into balance? Well, the first one is pretty obvious. This is a fat cell, and as you know, fat cells are not just bags of calories. They are active factories, and a fat cell will convert androgens to estrogens. A fat cell will convert testosterone to estradiol. It will convert androstenedione to estrone. And so the more fat a woman has, or the more fat a man has, the more estrogens are produced. But there's more to it. It's not just a question of having body fat. Fiber, plant roughage, reduces estrogens, and fat increases estrogens. Let me just walk you through this research a little bit. Okay, talking about fiber. Here is the liver, and your liver filters your blood. It will remove excess estrogens, send them down the bile duct into the intestinal tract where fiber carries them away. But what if my lunch was chicken breast and my dinner was salmon? How much fiber is there in those foods? There isn't any. They're not plants. They don't have fiber. So in that case, the estrogens are actually reabsorbed back into the circulation. And through enterohepatic circulation, they just keep cycling. However, once the diet is plant-based, that means every mouthful of food is loaded with fiber. That interrupts the enterohepatic circulation, and the estrogens are excreted. They're literally flushed down the toilet. Okay, let me make sure everyone is paying attention. Spam, does it have fiber or not? Okay, it's from an animal. Animal products don't have fiber, so here's my trash can. Away goes the spam. Goodbye. Now, how about KFC? Fiber or no fiber? Okay, too easy, isn't it? There actually is a little bit of fiber if you eat the carton. The chicken itself doesn't have any, so that goes away. Now, there are some things that actually had fiber at some point, but the factory removed it all. So all these things have to get gone. All right, so fiber will reduce estrogens because it carries them out, and literally they're flushed down the toilet. Now, the American Health Foundation in 1991 did a trial of 62 women aged 20 to 50. They increased fiber. They really about doubled it from 14 to 30. And what they showed was that over a 2-month period, estradiol and estrone diminished. Okay. So at UCLA, 1995, similar trial, but a smaller, 12 women. They did not only an increase in fiber, but a reduction in dietary fat, and found something very similar, that the low-fat, high-fiber diet would reduce estrone and estradiol. Then at Tufts University in 1994, they brought in 48 premenopausal women. What I mean by premenopausal is anytime up to menopause during their reproductive years. They tested a variety of 8 to 10 week dietary interventions, and some of them reduced fat, others increased fiber, or both. This was on a metabolic ward. They used isocaloric and weight-maintaining diets. And what they found is that by reducing fat alone, estrogens drop. By increasing fiber alone, estrogens drop. So the diet that I described for this young woman and suggested that she follow was a low-fat vegan diet. So it's maximally high in fiber and very, very low in fat. By the way, this is not only relevant for something like menstrual pain. The Women's Healthy Eating and Living Study at UCSD looked at women previously treated for breast cancer and found much the same thing. A high-fiber, low-fat diet will reduce estrogens, which is, of course, critically important for containing breast cancer. Okay, it helps to boost the fiber and cut the fat. Anything else we can do? This is Catherine. Catherine grew up in Louisiana. She was an Air Force aerospace engineer and went into Iraq in 2003. And when you're in a war zone and you're working really hard and you're eating what the government gives you, you don't gain much weight. But eventually her tour of duty came to an end and she was shipped back to the United States where her friends took her out for queso and macaroni and cheese and all these kinds of things that she had missed when she was overseas. And in fact, a friend knew that she loved macaroni and cheese in particular, and for her birthday gave her a case of 48 boxes of macaroni and cheese, which she ate for 48 days straight. She gained weight, but she also developed some pain that turned out to be endometriosis, which, as you know, is a condition of severe pain where cells that are lining the uterus appear to sneak out the fallopian tubes and implant all around the abdomen. Because they can implant on the fallopian tubes and on the ovaries themselves, they very often lead to infertility. Medical treatments, painkillers and hormonal treatments did not help. And finally, her doctor said, well, we can do a hysterectomy. But Catherine was 27 years old. And she and her husband had not yet raised a family, and she was not eager to have a hysterectomy. Her doctor explained to her that with her endometriosis, the extent of disease that she had, she was almost certainly infertile anyway, and she had nothing to lose by having it all removed. So under her doctor's advice, she scheduled the hysterectomy for 6 weeks later. Before she could do that, a nutrition expert guided her to follow a diet very much like I had described earlier. Plant-based diet, keeping oils very, very low, very natural foods. And what she discovered is she started to feel better. Very rapidly, she lost weight, her energy was improved, and her pain diminished. But the pain didn't entirely go away. There was some residual pain. So when 6 weeks arrived, she dutifully reported to the hospital. She was anesthetized. About an hour later, she woke up in the recovery room, and her doctor said, Catherine, I need to explain something to you. I did not do the hysterectomy because when I did the incision and I looked around your abdomen, your endometriosis is gone. He explained to her that she had quite a lot of scarring and she had some adhesions, but the endometriosis, the original disease process, was essentially gone. And so all the doctor had done was he just freed up some of the adhesions and he left her uterus in place. By the way, good on him for not doing the hysterectomy, although when it came to an explanation for this, her mother was in the recovery room with her and said, well, Catherine made a big diet change. She went vegan, and maybe that's it. And the doctor said, no, I don't think so. Can't imagine that food could have anything to do with something like endometriosis. And he attributed her recovery to, I guess, divine intervention. Well, the fact of the matter is that the diet changes that she made greatly increased the fiber, greatly reduced the fat. You would expect estrogenic stimulation of the endometrial tissue to be dramatically reduced, and that could help the endometriosis. She lost a lot of weight, and as it turned out, she was not infertile. She kept her uterus. She later had 3 children, and Catherine joined our staff as a Food for Life instructor to teach other women how they can take back their health. Okay, I mentioned macaroni and cheese, and that Catherine loved cheese, and that after she'd gotten back to the United States, she was jumping into cheese in a big way. Does cheese have hormones? Well, cows produce milk only after they are impregnated and give birth. And on every dairy in the United States and everywhere else, Cows are artificially inseminated every year, and they are milked during much of their pregnancy. They have a 9-month gestation, and during much of that time they are milked. What that means is that estrogens and progesterone will get into the milk product. It's only a trace, but it is more than enough to be biologically active. There is no such thing as hormone-free milk. I'm not talking about whether hormones are administered to the cow in the form of bovine growth hormone. What I'm talking about is that the cow herself makes hormones. She does it whether she's pregnant or not. It gets in the milk whether she's pregnant or not. But during the pregnancy, the milk goes way, way up. So the steps for tackling dysmenorrhea are to reduce the fat, increase fiber, avoid dairy products, and a low-fat plant-based diet really does that. Even minor deviations can lead to pain. If you're counseling patients and you're encouraging them to do this, you should let them know that you really have to do it vegan all the way and keep the oils to a bare minimum. And as they experiment month by month, they'll discover that the barbecue potato chips in the beginning of the month they'll feel a difference at the end of the month. Okay, at this point, let me turn it over to Dr. Cobb to describe the diagnosis and medical treatments for dysmenorrhea. Dr. Cobb?
Thank you, Dr. Barnard. So when taking a clinical approach to dysmenorrhea, it's important to figure out why does it hurt. And it's divided into 2 different categories, primary and secondary. Primary means that it's caused by the actual prostaglandins that are produced in the lining of the uterus during the menstrual cycle itself. Secondary, on the other hand, means that it's secondary to another problem in the reproductive system. Most commonly, this is going to be endometriosis, like you just described, adenomyosis, which is where the endometrium or the lining of the uterus has grown into the uterine wall, the muscular wall, which is also very painful, or fibroids or leiomyoma. And these are just benign monoclonal tumors that arise from the smooth muscle in the uterus that can become quite large and also painful. So when evaluating the patient, oftentimes they're going to tell you whether it's primary or secondary because the timeline of their pain will usually give it away. Primary dysmenorrhea is going to oftentimes start at the time of menarche, or they will have had painful periods since they were a teenager, and they may get better after childbearing. It's going to be worse on the first day of bleeding or even the day before their periods start, and then it gets progressively better. Secondary, on the other hand, usually has a later onset, and it's going to get worse over time. It's going to start sooner before their period, and it's oftentimes going to last even beyond the end of the bleeding cycle. So after getting a thorough history and a physical exam, pelvic ultrasound will help to delineate some of the different problems in the endometriosis, delineate different problems in the reproductive system, with the caveat being that endometriosis doesn't show up on ultrasound, which means we have to rely on laparoscopy. And that's pretty invasive to have to jump to surgery to do a diagnosis. The good news is that treatment is very effective and most women can feel better. The bad news is that if women are hoping to conceive or avoid surgery, a lot of these treatments aren't going to be appropriate. The first line of therapy is going to be birth control and non-steroidal drugs such as ibuprofen. Surgery, on the other hand, would need to address the cause of secondary dysmenorrhea, such as surgery for endometriosis, surgery to remove the fibroids, a uterine artery embolization, or more long-term medications like gonadotropin-releasing hormone agonists for the endometriosis.
Thank you, Dr. Cobb. Shifting gears, let's talk about fertility. In the course of the menstrual pain study that I described earlier that we were doing with Georgetown University, we asked all of the women to not use any hormone medications for obvious reasons. We wanted to see what a diet change would do for a hormonal condition. And if they were taking hormonal medications, that was a confounder. So that meant not to use birth control pills. As Dr. Cobb just mentioned, birth control pills are an effective treatment. So we asked all the women if they were sexually active to use a different kind of contraception. One of the participants, however, said, Dr. Barnard, you don't need to worry about me. My husband and I were evaluated years ago for why we couldn't get pregnant. It's not him, it's me. I don't ovulate. So we don't use hormones, we don't use anything. We don't use contraception at all. Well, the second month that she was on the healthy, completely vegan, low oil diet. She came into the research center and she said, Dr. Barnard, I've got some bad news and some good news. The bad news is I'm leaving your research study. The good news is I am pregnant. And she was pregnant. She gave birth to a healthy baby and then another and then a third. I ran into her years later. She had 3 healthy children. And so in the same way as the first woman had a diagnosis of dysmenorrhea, and Catherine had a diagnosis of endometriosis, and this patient had a diagnosis of infertility, in some ways you could erase all those diagnoses and say you're really perhaps just not in balance. So let me turn it back to Dr. Cobb, and let's talk about infertility diagnosis and the medical treatments.
So infertility is defined by the failure to achieve pregnancy despite unprotected intercourse or insemination during a certain period of time. And as you'll see on the screen, that period of time is based on the age or comorbidities. After that amount of time has passed, so for example, after 12 months of unprotected intercourse in a woman under the age of 35, then an evaluation is appropriate. Evaluation, of course, would begin with history, physical exam, and then labs that are going to test the ovarian reserve, ovulatory function, and then imaging such as ultrasound to evaluate the structural abnormalities. Male factor infertility can actually be the cause of infertility in up to 40 to 50% of couples. So getting a history of the partner's medical past and also checking the semen analysis are very important steps. Next slide. So the treatment, of course, is going to be guided based on the etiology of the infertility. It can be anything from diminished ovarian reserve, ovulatory dysfunction, tubal factor infertility, such as Dr. Barnard mentioned, scarring that can happen from endometriosis, uterine factors, such as congenital anomalies or fibroids, and male factor, like we just spoke of. And then the treatments vary everything from intrauterine insemination, ovulation induction with medications, all the way to major surgical repair of the reproductive system, donor eggs, and IVF.
Let's jump into the male factor a little bit here. There's a fascinating study that looked at men in a fertility clinic. This was in Rochester, New York. Men who ate relatively little cheese, a half a serving a day or less, happened to have higher sperm counts than men who ate a lot of cheese. A lot of cheese with 1 to 2.5 servings per day. The high cheese eaters had lower sperm counts. Also, studies have looked at sperm morphology and motility. It also seems to be affected. Now, the hypothesis from the researchers was that the traces of estrogens in dairy products are concentrated in the cheese, and even though it's only a trace, it is more than enough to affect something delicate like a man's fertility. So it's not only men who are affected, though. Women may be as well, in fact, by a variety of factors. Let's start with body weight. Researchers have long looked at body weight and fertility, and the sweet spot for fertility is a body mass index somewhere between about 18 and a half, up to about 22. Now, you know that the healthy body mass index, if we look at just about any website or guidelines, is 18 and a half to 25. Below 18 and a half, we're going to call that too thin. Over 25, we're going to call that overweight, and above 30, we'll call it obese. When a person is quite heavy, insulin resistance and a loss of sex hormone binding globulin and increase in androgens can really interfere with fertility. But also, if a person is too thin, you'll have less estradiol, and you can have suspension of ovarian activity. So it looks like the sweet spot is within the normal range, but sort of on the lower part of the healthy range without going too low. A fascinating factor has emerged from dairy products. This is lactose, the disaccharide that's the main nutrient in cow's milk. And as you know, lactose is a combination of glucose and galactose, and the lactase enzyme breaks the sugar into the 2 component sugars. And the galactose is what researchers have been looking at. Daniel Kramer at Brigham and Women's Hospital started looking at the decline in fertility in women. Now, as you know, if a woman is, say, in her mid-20s, her fertility might be at its maximum, And when she reaches her late 20s, early 30s, late 30s, her fertility is gradually declining. So Dr. Kramer looked at Thailand. Thailand is a country that doesn't need a lot of dairy products. Milkshakes are just not their thing. And the decline in fertility between the mid to late 20s and the mid to late 30s, the decline is maybe, call it 25%, something like that. Now, Brazil, a little bit more dairy, cheese, for example, and a bigger decline in fertility. The United States, New Zealand, these are countries where people know what ice cream is and yogurt and so forth, and the decline in fertility between the late 20s and late 30s can be as much as 80%. When we add other countries to the pattern, we see it's not a perfect relationship, but you do see a pattern forming, that it looks like dairy products seem to be getting in the way of continued fertility. Or to put it another way, they make a loss of fertility more likely. So, by the way, the Pearson's correlation here is negative 0.6, meaning a pretty robust correlation. And that could have been called a fluke, except that we're seeing the same thing with ovarian cancer risk. It looks like ovarian cancer is more common the more dairy women consume. So the hypothesis is that the milk sugar is attacking the ovaries, perhaps causing fertility issues and also aggravating the risk of ovarian cancer. This is a forest plot of studies, and you can see they vary, but overall, total dairy consumption is pretty strongly associated with ovarian cancer risk. All right, shifting gears to a different form of cancer, breast cancer. Estrogens are small hormones compared to something like insulin, which is a huge hormone that parks on the surface of cells. Estrogens are small. They can sneak through the cell membrane, and once inside the cytoplasm, they can sneak through the nuclear membrane, where estrogens can actually combine with your DNA. And they can attach to the DNA, they can break then one cell into two cancer cells that become 4 and 8 and 16 and 32. Estrogen can cause cancer. And a combination of 9 prospective studies in postmenopausal women showed a really clear relationship. The higher your free estradiol, the higher your breast cancer risk. Now, this is not ingested estrogen. This is not estrogen used as a pill. This is the estrogen your body is making. You want it to be in balance. Too much can increase cancer risk. Dr. Gary Fraser at the Adventist Health Study 2 found amazing relationships between dairy and breast cancer. And this is his paper, but I'm not going to give the details because Dr. Fraser will be with us shortly this afternoon. And before Dr. Fraser presents, Dr. Christie Funk will be with us right at the top of the hour talking more about breast cancer. So please stay tuned for these 2 presentations. Very, very important. All right. Let's talk about tackling these postmenopausal estrogens. Trimming body fat can reduce excess estrogens, as we were describing earlier. Testosterone, other androgens will go to estrogens. If you reduce body fat, that can help. Does that matter? It sure does. The higher the body mass index, the higher the risk of postmenopausal breast cancer. It's important. If a woman is thinner, she's less likely to develop postmenopausal breast cancer. And if she is overweight at diagnosis, if she loses weight, then her survival is more likely. Step 2, we want to avoid dairy products for all the reasons that we've seen. An Australian study done 10 years ago looked at postmenopausal women. And what they found was that those women who avoided dairy, that's the green bar on the left, had substantially lower levels of estradiol, circulating estradiol, compared to women consuming dairy products. Okay, so reducing body weight, avoiding dairy products, good idea. Also a low-fat, high-fiber diet, as we've seen. These are all ways that can help us control the hormones that can cause problems earlier in life, but also can increase the risk of breast cancer. Can foods help us to survive breast cancer? Dr. Funk will have a lot more to say about that, but just let me briefly mention a couple of quick studies that really got a lot of attention. The Women's Intervention Nutrition Study, or WINS, included more than 2,000 women. Everyone who was diagnosed with breast cancer and treated, and they had one thing on their mind, which was, will I survive this? Will the cancer come back? They were all postmenopausal women, and the dietary intervention was a reduction in fat, pretty serious reduction in fat, reducing meat, reducing added oils, and the target was about 15% of calories. And what they found was that the recurrence rate for all cancers was reduced by 24%. For estrogen receptor cancers, 42%. Estrogen receptor negative cancers, 42%. Estrogen receptor positive cancers, 15%. So this is important. Although we're talking about the effect of fat on estrogens, there may be other mechanisms as well, because cancer recurrence is diminished for both estrogen receptor negative and positive cancers. The Women's Healthy Eating and Living Study was over 3,000 participants, pre- and postmenopausal, all previously treated for breast cancer, and it was done at 7 clinical sites. Now, the two different diets that were tested, the comparison diet, the control diet, was what I'm going to call 5 a day. Have 5 servings of vegetables and fruits a day. The researchers had the idea that that was just normal advice, and so if they would tell women to do that, they really wouldn't do anything different, and they'd be a good control group. The intervention diet was 8 a day. 5 vegetable servings, 3 fruit servings, plus vegetable juice every day. Now, when the results came out, frankly, the two groups were about the same. It looked like 5 a day got you about the same result as 8 a day. And the conclusion was, diet doesn't make any difference. Wait, hold on a minute. Most people, men or women, aren't eating 5 a day or 8 a day or anything like that. And if you look at women who have had breast cancer and they're signing up for a research study to save their lives, and you tell them, let's eat 5 a day, it may well be that they actually did it. So let's look at that comparison group. It turned out that if you looked at those women who consumed a lot of vegetables and fruits and were physically active, their mortality over the 5 to 11-year follow-up period was 4.8%, not quite 5%. Those women who did not eat that much in the way of vegetables and fruits, 3.4 servings a day. Actually, that's more than the average in America, but not as much as the others. But they were physically active. Their mortality was about double. How about the women who increased their vegetables and fruits, but they were couch potato? Their mortality was high too, 10.7%. And then women who did not increase their vegetables and fruits, and they did not increase their physical activity, their mortality was highest of all. So what do? Do I reduce dietary fat, as in the WIN study? Should I increase my vegetables and fruits, as in the WELL study? Should I increase my physical activity? My answer is yes. Do them all. Cut the fat, increase the vegetables and fruits, and lace up your sneakers. Another word about dairy. Researchers looked at high-fat dairy products in women previously diagnosed with breast cancer. And what they found is that those women who had 1 or more servings of high-fat dairy, I'm talking about butter, whole milk, cheese, had about a 49% higher risk of dying of their cancer compared to women who generally avoided the high-fat dairy. So note to self, avoid dairy products, particularly the high-fat ones. Your patients will talk to you about soy. They'll ask you, does soy have hormones that could cause cancer? Soy has isoflavones in it. Genistein is the most common one and the best known. And the chemical structure does look somewhat like estradiol. And in fact, isoflavones in soy will attach to estrogen receptors. However, when you look at the effect on cancer risk, in 2004, a meta-analysis of 8 studies in Asians and Asian Americans, who, by the way, are a great group to study because some don't eat much soy, some eat phenomenal amounts of soy, and it gives you a much better ability to compare as opposed to, say, average Americans who frankly don't eat a lot of soy, and it's hard to do the study. But a 2004 meta-analysis of Asian and Asian Americans in studies found that a high soy intake was associated with a 29% reduction in the likelihood of developing breast cancer. And the same is true for breast cancer mortality. In a meta-analysis of 5 cohort studies, those women who consumed more soy were about 30% less likely to die of their cancer. And that was true whether they had an estrogen receptor negative cancer or an estrogen receptor positive cancer. So the point is, when patients come in and say, I read on the internet somewhere that soy causes breast cancer and that if I had breast cancer in the past, it'll make me more likely to die, precisely the opposite is true. And among researchers looking in this area, it's really not even controversial. The evidence is really quite strong and consistent that high soy consumption is associated with less risk of developing cancer and less risk of dying of it. So now let me turn back to Dr. Cobb. Menopause has lots of symptoms, and the diagnosis and medical treatment can be a little tricky. Here's Dr. Cobb to tell you about it.
Hi, thank you. So menopause is most of what I see clinically. It's a big part of my gynecology practice. And I'm quick to remind my patients that menopause is not a disease state. It's a physiologic event. It's kind of like adolescence in reverse. In America, the average age of menopause is between 51 to 53. And by age 55, 75 to 90% of women have stopped having a period. So the definition of menopause is 12 months without a menstrual cycle. The catch is that the symptoms of menopause can begin well before menses stop and can last much longer after the cessation of menses. Mean duration is about 4 to 10 years. What's going on? So during this time, the estradiol and the progesterone levels are going to decrease, and the follicle-stimulating hormone is going to increase. And while there's no lab test to predict when the last menstrual period is going to be, you can check an FSH to see if it's above a certain cutoff, depends on your local lab, to check the ovulation function. After ovulation ends, there may be a few more withdrawal bleeds. And it's during this time of what I lovingly call the hormone roller coaster that women have symptoms. Most common symptoms are going to be vasomotor, so hot flashes, warm waves, a personal summer, as one of my patients said, and of course night sweats, which can affect sleep. The other thing that's going to be the common denominator after all the hot flashes and night sweats are gone are the vaginal changes that come from the lack of estrogen.
Thank you, Dr. Cobb. Let me share with you the story that Anne shared with us. Anne told me that hot flashes were hitting her day and night. She had poor sleep as a result of waking up with a sweat many times at night, and all day long she was chronically fatigued. And she said, hot flashes can be tough on anybody. But if you are wearing a bulletproof vest and a gun belt, you can't really take it all off when your hot flashes arrive. She was a cop in Portland. Well, she heard about soy perhaps being helpful for hot flashes. So she went to the store, she got a little tub of soy protein, and she started taking it every morning. And she discovered that her symptoms really reduced dramatically. Then she stopped the soy drink to see what would happen, and the symptoms recurred. Well, is this real? Researchers in Australia did an interesting study. They brought in 58 women and did a 12-week trial of wheat flour or soy flour. And what they showed was that the soy flour does indeed reduce the risk of hot flashes on average. I have to say, though, what you'll discover in clinical practice is that when you work with women and you recommend soy products, you'll discover that they help for some and others don't really seem to get much effect. I haven't yet figured out if that really relates to the type of soy. So for some women, a soy supplemented diet means a glass of soy milk every day. For others, it means tofu or soy yogurt. For some, it means, as in Anne's case, going to the store and actually getting the concentrated soy protein and treating it like a medicine. A couple weeks ago, I was talking with a woman who took out her Instapot, and she made a half a cup of soy beans every day. She batch cooked and apportioned them out and found that in about 3 days her hot flashes were gone. We need more research on this, that's for sure. And I would encourage you to give it a try because all the side effects are good ones. There was a good meta-analysis on this, and looking at dietary soy isoflavones. You see mixed effects. If you are to the left, you see, looking out on the right of the slide, the forest plot, you look at those little dots. The 2 dots to the left means that the intervention was working. If the dots are to the right, that means it really wasn't doing much of anything. And you can see it looks like diets that are higher in soy isoflavones have a marginally useful effect. However, when you look at studies that combine supplements and also extracts of soy isoflavones, so you can pump up the amount a little bit higher, you do see a more robust effect in this case. I would encourage you to just try it out clinically if you like and see what happens. Okay, so let's put all this together. The first patient who had dysmenorrhea, or a person who's got endometriosis, or somebody who doesn't want to develop breast cancer, and we want to tackle our hormones. A healthy diet is fruits, grains, vegetables, and legumes. Legumes meaning beans, peas, or lentils. Don't forget your vitamin B12. You need vitamin B12 for healthy nerves and healthy blood, and the amount you need is very small, but 2.4 micrograms per day. So how do we counsel a patient to do this? And there's a certain technique that we use that I'll talk more about later on, but let me just walk you through it really quickly now. We talk to the patient about starting a healthy diet, and it's not really terribly complex. What you ask the patient to do, once you've described how a diet might help, is say, take a week, 7 days, and just check out the possibilities. What would you eat if you were following a completely plant-based diet? So the patient takes a piece of paper that says breakfast, lunch, dinner, snack. And for the next 7 days, their job is to write down ideas, things that they might actually eat if they were following a completely vegan diet. And you might have to give them some ideas. For breakfast, how about oatmeal or pancakes? Or instead of bran flakes with cow's milk, how about almond milk? You ever tried the veggie sausage? The patient might have not tried any of these. So for the next 7 days, they'll try them out. If they like them, they write them down. Then they go on to lunches and dinners, and they, for the first time in their life, have a pizza without cheese, or the bean burrito instead of the meat taco. And they discover that in an Italian restaurant, they can have spaghetti instead of the meat sauce. They can have the tomato sauce, the marinara sauce, the arrabbiata sauce. They can have salads and pasta e fagioli. At Latin American restaurants, Mexican restaurants, bean burritos, veggie fajitas, beans and rice. Chinese restaurants, rice dishes, vegetable dishes, tofu dishes. Extra points for Japanese because it's not only a source of lots and lots of plant-based options, from edamame to the cucumber roll, and asparagus roll, and sweet potato roll, but also they tend to not be so exuberant with oils. It's often vegan and very low in fat. Now, fast food chains are not necessarily the pinnacle of culinary art, but what you'll discover is that there are plant-based options too. So the patient comes back 7 days later and they say, I've got my list. These are the things that I found that are plant-based, and I like them. I've checked out the possibilities. Here they are. Now, step 2 then is to eat those foods. Take the next 3 weeks and eat the foods that you picked out. And the patient says, well, that's easy because I already know what I like, and it's only 3 weeks. At the end of that period of time, the patient will have discovered, number 1, that they are healthier. They might have lost weight. If they have diabetes, their blood sugar will have fallen. Their energy's better, their digestion's better. But also the way they feel about foods has changed. They don't really miss the chicken and fish that they thought they would. So if they stick with it, they'll find they get better and better and better. So here's an app that I'd like to encourage you to prescribe for your patients. It's free, it's not commercial, it's not promoting any food product. It's called the 21-Day Vegan Kickstart. You'll find it on your iPhone, you'll find it on your Android, you'll find it in English and in Spanish. Another app, the Nutrition Guide for Clinicians, you know about this already. This is for medical students and people in practice. 90 chapters on everything from Alzheimer's disease to varicose veins. Nutrition CME, go to nutritioncme.org and you'll get lots and lots and lots of hours of CME. Finally, this is my new book, Your Body in Balance, that discusses everything we talked about today and has recipes to boot. Let me thank you very much for your attention, and let me unshare my screen and we can take some questions.
All right. Thank you, Dr. Barnard and Dr. Cobb. So we do have quite a few questions, and it looks like we have about 5 minutes, so we'll get through at least a few of them. So first question, this is for either one of you. Can you treat polycystic ovary syndrome with diet?
Dr. Cobb, I happen to know that you have described a lot on this, and so let me turn that over to you.
Yes. We had actually wanted to include that in this lecture, and there was so much that it's going to warrant its own lecture sometime, but absolutely. Polycystic ovarian syndrome has a huge component of insulin resistance, which sounds familiar because that's what you hear about in type 2 diabetes. And so things that are going to be appropriate for the management of type 2 diabetes with diet are also going to help with PCOS. Absolutely.
All right, wonderful. Dr. Barnard, anything to add?
I might, at the risk of sounding self-promotional, in Your Body in Balance, I actually shared the story of a young woman named Allison, who is a registered dietitian, who deals with cancer patients and designs their diet, but she herself dealt with PCOS and finally used the same kind of diet that we've been describing to deal with her PCOS and found that she could get her cycle back into where it was, and conceived, and has a beautiful baby. So,
Oh,
and
fantastic.
Allison, if you're listening now, thank you for sharing your experience.
All right, so that sounds like a resounding yes, can treat PCOS with this pattern of eating. Next question, are avocados healthy? They're vegan, but is the fat still a problem when it comes to hormones?
Dr. Cobb, what do you think? Avocados, they are awfully delicious.
You know, I think at the end of the day, too much fat is too much fat. And yes, it's a better choice than, lardy bacon, but excess fat's going to be a problem because if you don't burn it off, it's going to be stored as fat. And fat is a really big place where estrogen is made beyond the ovaries, and especially after menopause. And so when you look at cancer risk reduction, you need to be at your ideal body weight. If you can be at your ideal body weight and have an avocado here and there, that's okay. But I wouldn't advocate adding avocados just for the health benefit of it, because it's still a fat.
I think it's true. You'll see somebody who's, if you're skinny and you have no symptoms, you don't have diabetes, you don't have a weight issue, and you have the occasional guacamole and avocados on your salad, I think you're going to be fine. But on the other hand, you will discover that a person who's dealing with pain month after month and they're thinking, I'm vegan, why am I still having this issue? Or why can't I lose those last 7 pounds or whatever? And they realize it's because I'm having an avocado every day or whatever, thinking it's good fat. So unfortunately, there are some dirty tricks in the world of nutrition, and one of them is these delicious avocados packed a lot of fat in them, unfortunately.
They are delicious, but yes, very high in fat. All right, thank you all. I think we have time for about one more here, maybe two. Next one, how do menopausal women deal with a diagnosis of osteoporosis in a healthy way? And what do you, both Dr. Barnard and Dr. Cobb, recommend along the lines of supplements or medications specifically for people on a plant-based diet who have osteoporosis?
Dr. Cobb, I know you see this every day.
Yeah, so osteoporosis, that's another topic for another day. But in general, the whole goal would be to not get to that point. And so making sure that you have a healthy bone mass before menopause, prevention's, better than cure. So making sure that you have, adequate calcium and vitamin D. Calcium, it occurs in plants. You don't have to be drinking cow's milk. That's kind of a myth. And then after menopause, not having an excessive amount of calcium supplementation and trying to get it through real food as much as possible, because too much calcium can actually be bad for your heart. The other thing that people don't consider with osteoporosis too is weight-bearing exercise. And as we discussed today, weight-bearing exercise is going to be really, really important for maintaining a healthy body weight. And if you have healthy muscle tone and you've stayed at your ideal body weight, let's say you do take a fall later, even if you have osteoporosis, you're probably less likely to break a hip and end up with long-term problems.
Dr. Barnard, anything to add?
No, I think that sums it up. You do need calcium in your diet, but cows don't make calcium. Cows just eat calcium in the form of grass. Hopefully you're not eating grass, but broccoli and kale and collards have you covered. With a little sunlight, you'll make the vitamin D to absorb it. And if, as Dr. Cobb mentioned, if you give your bones a reason to live with some exercise, then you've got it all put together.
Okay, well, that's a nice uplifting note, I think, to wrap on because we are 1 minute shy of our time. So again, thank you both, Dr. Cobb, Dr. Barnard. We really appreciate it.
Thank you, and we'll pick up at the top of the hour.